Hi, this is Taylor Mara doing my case study assignment. A little bit of background information. My placement for the semester was at Jamaica Hospital Medical Center. My supervisor was in charge of all outpatient services as well as inpatient acute rehab and inpatient dysphagia assessments throughout the hospital. I decided to do my case study on NR. Little bit of personal history. NR is a 52-year-old male. He lives in Jamaica, Queens with his mother and father in a single-family home. His parents are Spanish-English bilingual speakers, and NR understands and speaks basic Spanish, but English is his primary language and the primary language spoken in the home. His educational history. His highest level of education is a high school degree, and he also has a history of receiving special education services for what appears to be a general learning disability. However, it was difficult to collect more information regarding this. In terms of medical history and diagnosis, NR was diagnosed with Parkinson's disease in 2016, so about 1 year ago. And other than that, he has no significant or pertinent history of any illness or any other disease. So just to review about Parkinson's disease, it's a progressive neurological disorder characterized by a large number of motor and non-motor features that can impact on function to a variable degree. Individuals with Parkinson's often experience deficits in gait and movement, swallowing function, vocal quality, and can exhibit cognitive deficits as their disease progresses. Dysphagia in Parkinson's disease. So dysphagia is a common consequence of Parkinson's disease. Often there is coughing, choking episodes, and globus sensation. Oral pharyngeal dysphagia is multifactorial, but many patients with Parkinson's experience it. Even more common, patients experience pharyngeal dysphagia, characterized by incomplete UES relaxation and reduced UES opening, as well as impaired pharyngeal bolus transport associated with high intrabolus pressure. Voice deficits in Parkinson's disease. Nearly 90% of individuals with Parkinson's disease are likely to develop hypokinetic dysarthria over the course of their illness. This can include reduced vocal loudness and abnormal vocal decay, a breathy, hoarse, or harsh vocal quality, imprecise consonants and vowels due to reduced range of articulatory movements, with tendency of these movements to decay or accelerate towards the end of the sentence, reduced pitch inflections or being monotones, rushed, disfluent, palliatic, or hesitant speech. The initial consult with NR. So he was referred for an outpatient office evaluation to assess his swallow function and vocal quality. He reported increased tremors in the past few months, as well as reported stuttering with the onset of his diagnosis, stating that it felt like he had a heavy tongue, which made it hard for him to speak. His mother, who was present for the initial consult, also reported that even though NR was never a big talker, she's noticed that his vocal volume has become reduced over the past few months. First completed was an oral motor assessment. So NR presents with no marked facial asymmetry. However, his affect was mildly flat. NR presented with minimally decreased labial and lingual range of motion, strength and coordination, and lingual fasciculation upon protrusion. He also had minimally reduced diadokinetic rate and minimally reduced articulatory precision. A volitional swallow, throat clear, and cough were all present. The dysphagia assessment was conducted in the office, so it would be considered a bedside evaluation. PO trials consisted of puree, honey thick, nectar thick, thin liquid, soft solid, and regular solid. The oral stage, he had adequate acceptance, containment, and transit time, and no significant stasis post-swallow. For the pharyngeal stage, his swallow was pretty timely. Laryngeal excursion was palpable. There was no signs of aspiration throughout all trials and consistency. He exhibited stable work of breathing throughout the assessment and a clear vocal quality post-swallow. The overall impression was that his swallow appears to be within functional limits at this time. Next completed was a voice assessment. So his voice was perceived to be mildly dysphonic with decreased vocal intensity and increased rate of speech. He also had mild diplophonia during sustained phonation, and in open conversation, his speech was perceived to be mildly Palo-like. There was no expressive receptive language or cognitive linguistic assessment completed despite his history of receiving special education. This was because, one, it was not the purpose or the focus of the current referral, and him and his mother reported no changes in these areas since the diagnosis of Parkinson's. Based on the initial evaluation, the recommendations made were, one, to continue with a diet of regular solids and thin liquids at this time, to stop the diet if he wasn't tolerating it any longer or there was signs of aspiration, and the patient and his family were both educated on what these signs were. Also to initiate outpatient speech therapy 2 times a week for 8 weeks to address the following long-term and short-term goals. The long-term goals included improving vocal quality within conversation to improve independent communication with ADL-related social situations, and to improve labial and lingual range of motion and strength to increase fluency within ADL-related communication situations. There were 5 short-term goals established. 1, the patient will participate in oral motor exercises to increase labial and lingual range of motion and coordination with 80% accuracy given minimum cueing. The patient will participate in lingual strengthening exercises with 80% accuracy given minimum cueing. The patient will coordinate respiration and phonation to sustain target sounds for 5 to 10 seconds with appropriate volume with 80% accuracy given minimum cueing. And the patient will utilize compensatory speech strategies such as loud voice at the phrase and sentence level with 80% accuracy given minimum cueing. And finally, the patient will utilize pacing strategies such as tapping or a pacing board at the phrase or sentence level with 80% accuracy given minimum cueing. So a typical speech therapy session lasts 30 minutes. We would begin by reviewing carryover activities, oral motor exercises, respiration and phonation exercises, compensatory strategies, and assigned carryover activities. We tried to keep the progression of the session making sense. So we would start with the oral motor and move into respiration and phonation, and then use what we did in those activities to help with the compensatory speech and pacing strategies. And in terms of goals, they were established collaboratively between myself and my supervisor, who were both present for the initial evaluation. So I feel that they were very appropriate for this patient, considering his current level of functioning and where he would like to be at the end of the 8 weeks. So the first goal, participating in oral motor exercises to increase labial and lingual range of motion and coordination. So the reason we were doing this was to improve articulatory precision and overall intelligibility. Some of the labial exercises we did included protrusion, retraction alternating, prolonged labial closure, buccal fill hold. For lingual exercises, we did elevation, depression, and circular sweep. So his response to therapy. At the onset of therapy, NR had about 50% accuracy given an initial direct model, moderate verbal cueing, and mirror feedback. Halfway into therapy, so about 4 weeks in, he had about 90% accuracy given moderate cueing and 70% given minimum cueing. At the end of the 8 weeks, he had about 90% given minimum cueing and about 50% accuracy independently. So he did meet this goal. The second goal, participating in lingual strengthening exercises, also aims to improve articulatory precision and overall intelligibility. Some of the exercises we did were lingual lateralization with resistance, lingual protrusion with resistance, lingual elevation, and depression with resistance. At the onset of therapy, NR had about 60% accuracy, given an initial direct model, moderate verbal cueing, and mirror feedback. 4 weeks into therapy, he progressed to about 90% accuracy, given moderate cueing, and about 70% given minimum cueing. And then at the end of the 8 weeks of therapy, He had about 90% accuracy given minimum cueing and about 80% independently. So he met this goal as well. And the wonderful thing about NR was that at the end of every session, pictures like the ones that you see on the screen were sent home for him to practice the oral motor exercises on his own. And every time he came in to therapy, you could tell that he had been practicing because there was a progression. He was very motivated and very compliant with carryover activities, which really caused him to progress as quickly as he did. So the next goal, coordinating respiration and phonation to sustain target sounds for 5 to 10 seconds. So this aims to improve vocal quality and intensity, as well as to improve overall intelligibility. So some of the exercises we did were sustaining ah for first 5 seconds, then 8 seconds, then 10 seconds with appropriate volume, and also counting, aiming to count from 1 to 10 in a single breath, given appropriate volume. So during the initial evaluation, he was able to sustain the phonation for 10 seconds. However, his vocal intensity was quite low, and he experienced moments of diplophonia. So at the initiation of speech therapy, with moderate verbal cueing and an initial direct model, he was able to sustain the phonation at adequate volume for about 5 seconds, and able to count from 1 to 6 successfully. After he mastered that, he was challenged to shoot for 8 seconds and count from 1 to 8. And then he would progress to 10 seconds and counting 1 to 12. At the end of the 8-week period, NR was able to sustain the phonation for 12 seconds, given minimum verbal cueing, and attain adequate volume in counting from 1 to 18. So he met this goal as well. So the next goal is to utilize compensatory speech strategies, such as a loud voice, at the Fraser sentence level. So the overall goal of this is to improve vocal intensity and overall intelligibility. So exercises for this included repeating phrases and answering WH questions to sort of simulate open conversation. At times, reading passages were also tried, but given his underlying learning deficits, reading wasn't the most appropriate task for him. So instead, repeating phrases and WH questions were the primary activities completed during sessions. So at the onset of speech therapy, NR required consistent verbal reminders to utilize the speech strategy to increase his vocal intensity. Given moderate verbal cueing and intermittent direct model, he produced speech with adequate volume. By the end of the 8 weeks, he was successfully able to utilize the strategy with 80% accuracy given minimum cueing, and independently, it was only about 50%. Once we exited the structured task to simulate open conversation, that's when he needed more reminders to increase his intensity, but during structured tasks, he was able to complete this very well. So he did meet this goal. The last goal was utilizing a pacing strategy, so tapping or a pacing board at the Fraser sentence level. So this was to reduce rate of speech and improve his overall intelligibility. So similar exercises to speaking loud, so repeating phrases or answering WH questions. It was found that he experienced more success using a pacing board versus tapping. Having the visual and tactile cues appeared to help him more. So at first, he required consistent verbal reminders to utilize the strategies, but at the end of the 8 weeks, he successfully utilized pacing strategies with 90% accuracy given minimum cueing and about 60% independently. So he met this goal as well. So his progress report. At the conclusion of the 8-week therapy period, NR had maximum improvement, meeting all 5 of his short-term goals. He demonstrated increased self-awareness of his current deficits and increased independent utilization of compensatory strategies, such as speaking loud and slowly. Because he was so motivated and so compliant with carryover activities, his progression was great.